I will take a little bit of a different approach. I've got different sorts of talks for what I think or assume are different interests that different groups of people might have for all grades and all levels of adults in education. So I did a little mixing and matching, but I will focus on targeted therapy. I think one of the problems is, what does targeted itself mean? It is kind of a lot of these words that we use, they're a little bit vague, and sometimes people use them differently. I mean, we'll go over a little bit of biology because I think that's useful. It'll give you an idea why it's so difficult to do some of these, improve on some of these medicines. And then I'll talk about the side effects in combination. I won't talk a lot about resistance to these therapies, but you'll get a sense from the trials how we deal with resistance. And then you've heard about two major types of therapies, which were big breakthroughs. I see people from different eras and even people with different melanomas. There's some practical questions you have to ask, because we can go through these lists of therapies and compare and contrast, and ultimately a decision has to be made. And I'll comment on the types of questions people might want to ask. So we'll start from the beginning. What is BRAF? Even that is a question in and of itself. Well, we use it to refer to the gene. Genes code for proteins, the same way letters of the alphabet spell out words and give meaning. The proteins can be thought of as machinery. And one of the reasons that biology is such a difficult field is a lot of what happens you can't see. You're indirectly seeing it. Even with the best pictures, people take pictures that are known as X-ray crystallography. There are microscopes, but even at that level, things are very small, and in my mind, you're really inferring what's going on. Ultimately, what's important is what happens to you, whether we know how something works or not. And then BRAF is also a protein coded for by the gene. So I think of them as machines that have functions. And when a mutation occurs in that machine, the functioning of it can change. Now, just because you have a mutation, it doesn't mean that it's bad. We are different, but some mutations we know are associated with problems. So it's not that you have a mutation or a certain gene, it's what specifically is the gene and what specifically is the mutation. That also affects your therapy. I want to go through some definitions before we get to the clinical data, because I think you see these. I did talk about mutations as a change in DNA. It may or may not change a protein, and so you don't know whether it's important for you unless you've studied that. There's a couple of terms that show up a lot on these curves. I do want to make a point to differentiate them, because it may or may not be something. If you're like me, I just want my doctor to tell me what to do, because I got to work, I got to go to the clinic, I got to do a lot of things, and I really don't want to analyze. But if you want to analyze, there are two terms that show up regularly: progression-free survival. We all know what survival means. That's what we do every day. And overall survival. They are potentially very different. And when you look at reports, it is worth knowing what these mean. Progression-free refers to at what point, when usually you're on some kind of medicine, does your tumor, can be in reference to anything actually, but in terms of cancer, when does your tumor grow? And overall survival, in a way, looks at how long you've lived. Now, these things are analyzed statistically, so they're a little bit obtuse, but they generally, if you think of the meaning that way, they're helpful. The other point I want to make for all cancer growth, but for melanoma in particular, you're talking about individual cells. And at some point, you can see a ball of cells. But oftentimes, this is something you always have to bear in mind. if you have a scan that doesn't show anything, it doesn't mean you don't have something that can't be detected. That's unfortunate, but it's better to not have anything on the scan than to have something. But that is a concept that you have to keep in mind as a patient, and it's important. So we're talking about targeted therapy. Where does it start? Does it start with, atoms, molecules? We think of molecules as the smallest building blocks of proteins. If we think of it as just atoms, well, it's pretty simple. We can think about the atoms that make us up, but it doesn't really help us. That's not exactly what we're targeting. I mean, we're mostly made up of oxygen, carbon, hydrogen, and in terms of molecules, it's mostly water, protein, and fat. So conceptually, it's maybe simple if you break it down, but what happens with all of these atoms, molecules, and building blocks is ultimately you're dealing with tissue. And that's really the level we're talking about. So you have the whole body, but it's made up of tissue, and then cells, and then you get into molecules and atoms. I've drawn melanoma there by 3, and we're talking about cells there. That's, what we're talking about, what we measure. A whole bunch of cells together we can see on a scan. There are other ways to measure, and at the molecular level, well, BRAF protein could be considered a molecule. And so that's the level that we work at. So this is a ribbon diagram of the BRAF protein, okay? I've just estimated the scale. These are 2 BRAF blockers, so that's one way to define targeted therapy. You have a mutated or abnormal protein, and you have these small molecules. That's kind of the way we think about it. This is about the scale you're talking about. You can see these represent atoms, and so a bunch of atoms put together in this big protein, big machinery. That's the way we think of targeting. And that's a good way for you to think about it. Obviously, it's more complicated, but that's what a target is doing. It is affecting this protein and whatever else the protein does. So then we get to these complicated pathways. And I think the important thing is you can think of a cell as a bag of water with a bunch of machinery, okay? And if you look at the machinery, this is simplified. These are all proteins. It's kind of like a pinball machine. You put up a ball, and there could be signaling anywhere if this were a pinball machine. And that's what makes it so complicated. Even if you think that this set of proteins is what's causing the cancer to grow and you block it, there may be ways to get around it with these other pathways. So you have a bunch of, one way to think about it is parallel circuits. I'm simplifying, but the idea here is there are lots of ways for a cell to grow. So although we're not going to talk about resistance in detail, the fact that there are many ways for a cell to survive is what makes it challenging, and that's how sometimes people will benefit from a medicine and then develop resistance. It stops working. And by the way, you can also think of targeted, you could also think in a way of immunotherapy as targeted. As you saw from Dr. Dowd's talk, you are with the protein, the machine, which is whether it's nivolumab or one of the similar drugs, it's a big machine interacting with another machine or receptor, and some of its effects are on target. So again, we're talking about at the cellular level, a bag of water with a bunch of protein. These colors represent ways of looking. We can't directly look at the proteins with our eyes. This is DNA, and the cells are dividing. This comes from a UK website. All of the stuff I have, by the way, I can either provide to you or it's the papers are published papers. And you have this membrane around here, and there are lots of proteins and machines to block. So back to the clinical problem, BRAF is, in this case, a protein, okay, a machine. When it's mutant, it behaves differently. You get excess proliferation, okay? So you've changed the meaning of the word, the DNA, and then you've potentially changed the machine. As I told you, not all mutations are bad. If you were to get tested, you would see all sorts of mutations. We don't necessarily understand all of them. Some of them may have been in your family for a long time. So the issue here is machinery and blocking machinery. And at the end of the day, those malignant cells, the melanoma cells, bags of water with a lot of machines that make them grow forever, we want to destroy those at that level, and then you would see that if it works as shrinking tumor. So inside the cell, there's a nice review recently in a British journal called The Lancet, but it's the same sort of idea. I think, my point of these diagrams really is not for you to understand them, but to let you know there's a lot of machinery, and that's what makes it so challenging. There are a lot of ways for things to become resistant, a lot of bypasses that cancers can take. And although we study a lot of, scientists study a lot of these proteins, it's very difficult sometimes to put the big picture together. So now to the clinical part, and take a breather. This is a circle diagram that shows you the amount or the proportion of different mutations. We're just going to focus on the blue. The blue is BRAF, what we're going to focus on, because that is a successful targeted therapy, and if you define it as a small molecule interacting with a mutated protein, it definitely fits in that definition. So you have cutaneous and several other subsets of melanoma. We're not going to spend a lot of time on mucosal and uveal. We do use the same drugs. I would argue that they are less effective, not completely ineffective, but the problem with targeted is you need the target. You notice there's some blue in these mucosals. That's internal skin. If you think about it, your skin continues and touches your mouth all the way down to your bottom. But there are changes, different types of these genes. And then when you get to uveal, you don't see the blue at all. So you would not expect these BRAF targeted therapies to work. And at this time, we don't really have targeted therapies specific for this. And marginally successful, I would say, targeted therapies for mucosal. But the immunotherapy is used by most of us in those settings. Now, a quick overview of what we're talking about. I have room in my heart for all of these drugs and drug companies, so if I show something, it's not because I prefer one over the other. I'm not going to share that with you today. And so I think you have targeted therapies and immunotherapies, and you can see there are a number. And it's for a separate talk, but you should ask yourself why there are so many of the same or similar type of drug. And there are all sorts of jargon, but I told you what progression-free survival was. It's the point where your cancer starts to grow, and overall survival is sort of how long one lives. So when you look at these numbers, you'll see other jargon in here that are very tricky to interpret. There's a number called a median. It's not an average the way you might think about it. It's a 50% point. So half the people are below, half the people are above. That's, in my opinion, a very tricky number. There are reasons, I'm told, that statisticians utilize that number, and it definitely has value using a median. Now, these are not direct comparisons, so you also have to be careful, right? I just told you there's different types of melanomas, and so obviously if you had a different set of melanomas, you'd expect a different set of responses. If you had a different set of people, you'd expect a different set of responses. But this is just to kind of give you a flavor. There are a lot of drugs, but it's really mostly about targeted. This drug is new, the latest one to be approved, and all of these target BRAF. And these are the immunotherapies that you've already heard about. And so this slide I added at the last minute because these drugs are used mostly in mucosal and melanomas with similar gene kit. And so there are other targeted therapies, but their level of success is much rarer, okay? So we'll go to the clinical data. Small molecule inhibitor binds to a protein. And I showed you the size difference. And usually the protein target in this case is mutated. It doesn't have to be. And before I show you those curves, I'll remind you some of the endpoints. There's something called response rate. That's about shrinking the tumor. Of course, it's important to start. You know, a benefit starts by shrinking a tumor. Progression-free I've told you about, and overall I've told you about. And then I've mentioned about median, okay? But I tend to emphasize this for better or for worse, but I'll show you now the actual data. The latest data is available and was presented at our ASCO meeting, okay? This involves two curves here. When you look at these curves, these are the number of people that have made it out this far for whatever reason. This is a technical point, but obviously if you started with 2 and 2, 2 patients in each arm, you might wonder about it, right? So usually there's no such absurd trial, but if the numbers start to get small, it gets difficult to interpret. But the point here is the combo, which is the encorafenib and its MEK inhibitor, which I will talk about, 2 drugs versus 1 targeted drug. It appears this is overall survival, the endpoint I like to look at, and this is months. So we look at these curves, for example, 24 months at 2 years, and we have percentages, okay? So not everybody responds, right? And that's true with all of these drugs. It's important, even with these major breakthroughs. I talked with the deal about incremental benefits, but these were major, major benefits. They weren't incremental. Incremental small benefits are important, but I think that, you know, these were quite major. And the other thing you have to keep in mind is these trials tend to have a lot of limitations for recruitment. And that's something we can talk more about. So it's really representing those of you that walked in here and are pretty healthy. Sometimes people are quite sick when they're diagnosed, and they're not necessarily represented on these trials. This is side effects. I just want to make a point. The green is the single agent. This is not meant to disparage it. And the combo are listed here by color. I mainly wanted to go over, give you a flavor. I know Dr. Sweater talked to you, but patients on these therapies can get rashes. I'll show you some data. If you use 2 drugs together, a BRAF and actually a MEK inhibitor, you actually get less skin side effects. Serous retinopathy is an eye side effect, fevers, liver elevations, that's blood test, and so on. Photosensitivity is, I think it's fair to say, increased with vemurafenib. So that is a difference. So sometimes even though these drugs are similar, they can have differences. It's not always easy to tease out. And increased bilirubin goes together with liver. So the other set of side effects I want to show you, similar type of curve with overall survival. This is dabrafenib and trametinib versus 1 drug, 2 drug versus 1 drug. And I'll go to the side effects, but the point of these slides is these days we treat people with 2 targeted therapies together, not 1. And then side effects, I'll make this point. I think the most important thing, Adil talked about grading, and grading is an important way to communicate, high grade being worse. But in real life, it isn't that you had grade 3 fatigue. You usually end up with multiple side effects. Some of them are low in grade and may not bother you, or maybe you have 3 or 4 side effects that are low in grade and they can also bother you. So it's really very individual. When we grade these, we're trying to get an overall sense, an average, okay? But, you know, many of you may not be in the average, okay? So other side effect I want to make a point about is diarrhea, muscle aches, fevers. Oftentimes people get these together, night sweats. So looking at them individually is useful academically, but a person usually gets all of them. So finally, comparison to targeted to immunotherapy. In general, I think people would agree if you have the mutation and you can get targeted, in most situations it works quick. And I'm talking about 2 drugs together. There are different side effects. These are generally pills, and most immune therapies are intravenous. And then this is a question you should always ask. The length of treatment for both, I would argue, in a given individual is unknown. People always ask me, how long do I have to be on it? Breather, and then back. What is the future? There are lots of pathways, proteins, lots that people are working on. And in here, you've got a number of new compounds in gray, drugs that we know about in white. So RAF and MEK, which I didn't talk about the 2 drugs, but the reason that the 2 drugs are given, they target both this protein and block both this protein. And then for immunotherapy, it's a similar type of thing. There's a lot going on. And it's not important to know the mechanisms. It's just for you, unless you're interested, it's important to know that people are trying to work on them with different drugs in gray. And overall, this is ipilimumab, Yervoy, maybe a little bit lower. Overall, this is representing immunotherapy combination targeted. You can see these curves run together. They're at least at these time points in an average set of patients, they're pretty close. So don't sweat your decisions too much, but it's definitely something to think about. So what might you want to know as a patient? How does the medicine help me? Is it curative? You know, what is the evidence if you're interested in that? What are the side effects? What is the trade-off? And most important, this doesn't go into the grade. How long do these side effects last? Are they permanent? Many of them are reversible. This time dimension, it drives me crazy. It's just not at all in the scope. But neuropathy, which is can be irritating nerves, if you don't take a medicine for it, it's grade 1, but it may last your entire life. So these are things to think about as a patient. And we should think about these too, and we try, but it's very difficult. What are your choices, and do you even qualify for targeted? And what about a trial? And then finally, how long is therapy? How much does it cost? This shouldn't be an issue, but it has shown up regularly as an issue in my clinic with orals because there's a copay. So this, I don't know what to tell you about this. I'll get upset if I keep talking about this, so we'll skip it. And what are the purposes of my tests, my scans? Because we all do it a little bit differently. You know, do you want the doctor to just keep, are you like me, just tell me what to do, I got to go to work? You know, I don't want to know I trust you, or do you want to get into these details? They are important, but we do think about them, whether it's Dr. Tsai, Dr. Sweater, Dr. Dowd, and I forgot your name, but we all think about it. I apologize. So, and, you know, the end.